Jaco Vorster, one of the registrars in UCT, and now presenting on esophageal foreign bodies this morning. I'm quickly going to go through two cases we recently had in the ward, and then I'll go through some of the literature. So the only disclosure is that consent was obtained from the patients to use the imaging. Our first case is a 15-year-old boy who had an acute onset of adenodysphagia after an ingestion of a food bolus. The food bolus was a piece of chicken which included some bone. And it did describe the chicken foot. The patient on the presentation had partial obstruction. He was still able to tolerate his own saliva. He had a delayed presentation to our institution due to prolonged transfer times between the local clinic, then to the district hospital, and eventually to us. So his initial X-ray at the local clinic showed no extraluminal air, and a foreign body, a bony foreign body was seen at the level of the thyroid. Initial endoscopy was performed at the secondary level hospital by the general surgery team, and this was at about 60 hours post-ingestion. It was a flexible endoscopy, and they failed to retrieve the bolus of forceps, but they did manage to visualize the bolus. After this, the patient remained clinically stable and was discussed for transfer to our facility for rigid endoscopy. At that point, the white cell count was 8.5. This is the initial X-ray that was taken, and one can see the inhibition of a bony foreign body at the level of the esophagus. The patient, on arrival, was taken to theatre within 2 hours for emergent rigid endoscopy under general anesthesia. Chicken bone was found to be embedded in the posterior wall of our hypopharynx mucosa at about 14 centimeters. It was a difficult esophagoscopy, and the foreign body was only seen on the second pass to be sitting under the mucosa. It was successfully retrieved with a grasping forceps. There was, however, a 4 centimeter linear mucosal injury at the site of a foreign body. From the endoscopy, it was not, we weren't that sure whether it was full thickness or not, but it did not obviously seem full thickness. And then the rest of the esophagus distally looked normal on a second pass. This is a piece of chicken bone that we retrieved. Then in theatre, a nasogastric tube was placed under direct vision. The patient was then started on broad spectrum antibiotics because we weren't sure there was a perforation or not. And the patient was kept NPO and sent up to the ward. Control swallow was then ordered. And this was a picture of a control swallow. There was no leak seen on the contrast swallow, so the patient was then progressed to a full ward diet, and he did well and discharged the next day. Our second case, this was a while ago, was an elderly female who presented with acute onset adenodysphagia after eating chicken. It was a chicken worm bone in. The patient was also edentulous, which is a risk factor. She presented approximately 6 hours after the ingestion to the hospital. Clinically, her vitals were stable. She did, however, have cervical surgical emphysema clinical exam, which was a red flag, and then also pre-air was seen in a lateral neck X-ray. So this was her initial neck X-ray. The surgical emphysema and extraluminal air visualized. At this point, we were quite concerned for a esophageal injury, perforation, and contrasted CT scan was ordered. On the contrasted CT scan on the first slide here, one can see some extraluminal air sitting around the larynx. And then further down in the neck, the free air continues down. And then in the chest, one can visualize in the esophagus some foreign material mixed with some air, and possibly some air locules behind the esophagus. After the scan, cardiothoracics was consulted to assist the patient. They advised that we get a contrast swallow for the patient. Contrast swallow revealed about a mid-esophageal foreign body. One can see on this surrounding here where the foreign body is, with the contrast sitting next to it. No obvious leak or perforation was seen on this esophagram. They then advised us to refer the patient on to upper GIT surgery for a flexible endoscopy, which was done. Upper GI did a flexible endoscopy and they saw a lateral pharyngeal wall injury with perforation. They managed to disimpact the food bolus from the upper to mid esophagus, and then the rest of the esophagoscopy was normal according to the report. They did send us a small video, and then here one can, as they come up, see the pharyngeal wall injury up here. And then as I go down, you can see the esophageal foreign body. So this patient was started on NG feeds after retrieval of foreign body, and antibiotics were given for 5 days. The patient was successfully transitioned to a full board diet and discharged without any further complications. So just having a quick look at esophageal foreign bodies, there is a few physiological narrowings of the esophagus that frequently trap foreign bodies. First is the pharyngoesophageal junction, the esophageal sphincter at the level of C6, which is about 15 centimeters from the teeth. The next is the crossing of the aortic arch at T4, about 25 centimeters from the teeth. And then the crossing of the left main bronchus at T5, about 28 centimeters from the teeth. And then the gastroesophageal junction or the lower esophageal sphincter at about T10, about 40 centimeters from the teeth. So predisposing conditions to food impaction and esophageal foreign bodies is structural abnormalities like strictures, Schatzky rings, webs like inflammatory Vincent syndrome, and diverticuli. And then medical conditions of note is eosinophilic esophagitis, especially in patients with younger patients with trapped food boluses who does not have strictures or webs. So in one study, they found that up to 50% of these younger patients with no structural abnormality actually had eosinophilic esophagitis. And then other diseases like scleroderma, diffuse esophageal spasm, and achalasia. You just need to be kept at the back of the mind when assessing these patients. Types of foreign bodies that can get trapped, mostly they are inorganic or organic. Inorganic is toys, dentures, coins especially in children, and button batteries. And these are, as a rule of thumb, regularly radiopaque and can be easily seen on plain film X-rays. And then organic foreign bodies like fish bones, chicken bones, food boluses, especially meat boluses, more likely in edentulous patients. And these are not always readily radiopaque and visible on plain film X-rays. Other types of foreign bodies are sharp objects, needles and safety pins and screws that also need special considerations. So patient populations, children, like I said, they most likely will swallow coins, marbles, mostly inorganic foreign bodies. Common size where they get stuck is at the upper esophageal sphincter. And then in children, if there's a swallowed coin, one must always make sure it's not a button battery, So if you're not sure, they need to go to theatre emergently. Otherwise, you can look for the double shadow of the X-ray to exclude the button battery. Psychiatric patients, they often have multiple objects. And for them, a flexible endoscopy to also have a look at the stomach is usually indicated. Make sure there's not lots of other foreign bodies that's also trapped. Edentulous patients are more often food boluses, and the most common site of obstruction is the lower esophageal sphincter. Complications from esophageal foreign bodies, especially with delayed presentation, is esophageal erosion and perforation, autoesophageal fistula, trochoesophageal fistulas, periesophageal abscesses, mediastinitis, and then late complications is strictures. So usually on history, they give a history of acute onset dysphagia and have some adenophagia with that. One should also inquire about the type of foreign body, as that will impact your management, the time of ingestion that will determine the urgency of your management. You can ask them to point to the area of most discomfort, whether or not they're drooling or have the inability to swallow liquids, because that's indicative of complete obstruction. A prior history of esophageal pathology, prior history of dysphagia, and then chest or abdominal pain. So examination, good place to start is the airway to make sure we've got a patent airway, not a threatened airway. And then oral cavity and oropharyngeal exam, especially with fishbone ingestion, to look at the subsites. Those can get stuck in. Examining the neck for surgical emphysema, and then tenderness around the sternocleidomastoid that can be with abscess formation. It's also prudent to listen to the chest for wheezing, especially a new onset unilateral wheeze. That's a warning sign. And then if a flexible pharyngoscopy to look at the base of the tongue, molecular, peripheral size. So fishbones, about 60% of them get lodged in one of these sites: the tonsils, base of the tongue, or the peripheral fossa. And just having a look at the management of fishbone ingestion. This is from an article where they suggested that if a foreign body is seen on pharyngoscopy or clinical exam, then you proceed with removal, either under local or general anesthesia. If you do not see it, you proceed to a plain film X-ray. Thereafter, it's individualized, but in some patients where you're unsure, you can use a uncontrasted CT scan, where if it's positive, you proceed to theatre to remove. If it's negative, but there's tissue swelling, then you admit them and observe them for 24 hours to see how they progress. And if it's normal, then you can discharge them and follow up date to see. Just some other clinical features. So foreign bodies that stuck in the upper third of the esophagus is usually well localized by the patient because of a good innervation, versus foreign bodies in the lower 2/3 of the esophagus is poorly localized by the patient because of poor innervation to those areas. And then other things they can have is vomiting and retching, hematemesis, and often they can have blood-stained saliva. And then airway compromise is quite a rare feature. But red flags, like mentioned, is the surgical emphysema, significant cervical tenderness, fever or signs of systemic sepsis. If they've got chest pain, especially if it's radiating to the scapula, if there's associated tachypnea, dyspnea, then one needs to be concerned about an intrathoracic perforation. The patients with delayed presentation, they need special consideration. Patients with complete obstruction, they need to be managed, and then patients with airway compromise. These are the patients that need to be seen extremely urgently. In the literature, previously was described Mackless triad for middle esophageal perforation, which is a vomiting of severe chest pain and subcutaneous emphysema. But in recent studies, I said it's only seen in 12% of patients with esophageal perforation, so it's not a reliable clinical sign. Workup for this patient, basic bloods, but that's guided by a clinical scenario. Not all patients need basic bloods. If it's an acute presentation with no warning signs, they don't necessarily need bloods. X-rays, usually 2 views. I'll chat now about X-rays. And then contrast swallow is used by some centers. Cardiothoracics here routinely ask for a contrast swallow in these patients to exclude a perforation. But you can also use it to confirm spontaneous passage. If a patient still has discomfort, but is now able to swallow, and then with contrast swallows, if a patient is completely obstructed, there's a higher risk of aspiration. And then also it makes the endoscopic visualization afterwards more difficult of a foreign body. CT scans, it's not routinely done, and it's based on an individual case, but it can help to locate non-radiopaque objects, and it also helps to assess for complications of esophageal foreign body ingestion if any of those are suspected. So X-rays, some literature said that adults that present acutely but is planned for endoscopic removal do not need routine X-rays if a complication is not suspected. But it does assist with localization of an object if it's radiopaque. It helps to differentiate coins from button batteries. Organic food boluses with bones, only 20 to 50% of the bones are actually visible on these X-rays. And then objects that lodge in the esophagus tend to orientate in the coronal plane, whereas objects lodged in the trachea tend to orientate in the sagittal plane. So the initial approach to these patients, all foreign bodies require removal within the first 24 hours, but the majority will actually pass spontaneously. So patients that need emergent esophagoscopy on referral, patients with complete esophageal obstruction, button batteries, and sharp objects. And patients that need urgent esophagoscopy is any foreign bodies that hasn't passed within the 24-hour frame period. So there is institutions that admit patients with only partial obstruction and wait overnight to see if they will pass a bolus and only then proceed to esophagoscopy. When just looking at types of esophagoscopes, the two main are flexible and the rigid endoscope. Studies that compare the effectiveness said that both has comparable effectiveness in removing foreign bodies, both more than 90%. For us, we routinely use a rigid esophagoscope, and they also have comparable complication rates. Even though the rigid endoscope has a high perforation rate and the flexible, it's not deemed statistically significant. So just looking at the points on the rigid, better for sharp pointed objects because they can be retracted within the esophagoscope and then removed to avoid airway aspiration, or to avoid further mucosal injury as the foreign body is retrieved. It gives better visualization of the upper third of the esophagus, so it's better for proximal foreign bodies. There is airway protection because patients are routinely intubated for rigid esophagoscopes. In the recent European guidelines for about esophageal foreign bodies, there's no mention of rigid esophagoscopy, so it seems to be less. There is a slightly higher incidence of perforation. For flexible endoscopy, they can be done under conscious sedation, but with problems you don't have airway protection unless you use a special device like an overtube. But they do get better visualization with distal esophagus, and they're also good if you need to inspect the stomach or the abdomen. So techniques that's described is to gently push the food bolus into the stomach if it moves freely. And this is especially with if you use a flexible scope without an overtube, because as you pull it out, the patient can aspirate it. And then the use of grasping forceps to retrieve it, pull it upward. When you're flexible endoscopes, there's quite a few tools one can use, like nets and baskets and snares. Top objects where they say it is better to use rigid esophagoscope, previously said. And then following the removal of foreign body. You should always do a second pass of the endoscope to look for mucosal injuries, perforations, strictures of the esophagus. And then also to pass view under direct visualization if indicated at the time of your scope. No esophageal injury to avoid progression or diet. Let's try the next 4 hours. You can try different modalities. So if you previously used a flexible endoscope, you can use a rigid endoscope and vice versa. You can use a different technique. There's still failure. Some people say patients are completely obstructed to abandon procedure, send them back to the ward, wait a few hours and attempt again. Then as a last resort to use a esophagotomy and so perforation is very important to identify early on, as it can very quickly lead to mediastinitis, sepsis, multi-organ failure, and death. And it's got quite a high mortality rate. And the etiology of esophageal perforation, so endoscopic perforation accounts for more than 50% of cases of esophageal perforations, and then the rest, Burhofer or spontaneous esophageal rupture is about 10%, foreign body ingestion only 12%, and then trauma and hydrogenic surgery and malignancy. Just looking at the risk of perforation with endoscopic procedures. So flexible endoscopy, a diagnostic flexible endoscopy carries a 0.03% risk. Rigid diagnostic endoscopy carries a 0.11% risk. Stricture dilation up to 2%, therapy up to 5%, and then pneumatic dilation is used for achalasia up to 6% risk. Differential dilation will give you a similar picture. Is Burhofer syndrome, myocardial infarction, pericarditis, and malarial tears. The initial management of these patients is to keep them for us, give fluid resuscitation as needed, start broad spectrum antibiotic cover like augmentin, and then clindamycin, ciprofloxacin, and penicillin allergy. Consideration for antifungal cover, especially in severely immunocompromised patients, or if there's evidence of esophageal candidiasis on your scope. And then either ICU or high care if needed, and then a discussion team for non-operative versus operative management. Non-operative management can be done in patients that's clinically stable with no sign of systemic sepsis, only got mild pain, perforation of less than 2 centimeters of a contained leak, and the leak must be draining into the lumen and not walled off. And there must be no gross swelling of the surrounding tissue. Indications for operative management are large perforations, uncontained leaks, significant swelling, or if there's underlying obstruction like a malignancy. So just signs of cervical esophageal perforations, neck pain, tenderness, dysphonia, and then vesicular emphysema, whereas intrathoracic they can have hematemesis with dyspnea, adenodysphagia, and the chest pain. So just as a last slide, I don't think management of perforations is the scope of this talk, but just quickly, there is endoscopic management options, which includes closing devices. You can stent over perforation and allow it to heal, and then endoscopic back dressings. Then surgical, it's dependent on the site and size of perforation. We use cervical, intra-abdominal, or thoracotomy approach, usually as a primary repair. Patients are unstable and can't tolerate repair at the initial surgery. They offer diversion with esophagostomy, and then revision at a later stage. And then if it's a severe injury, they will require esophagotomy with reconstruction at the later stage.
Thank you very much, Jaco. Thank you. Very people mentioned that I've never used it. Okay. Any mention of that in your reading?
So there's a few things I mentioned. So they use buscopan and then in favor sometimes glucagon to assist the passage, but the evidence is unequivocal for both.
You reading?
Yes, in the one guideline they mentioned that you can attempt it because there's no harm trying it, but it has extra cost, but it has, when they compared patients who use it and hasn't decreased the amount of endoscopies needed.
Okay.
So you don't save your patient endoscopy by prescribing it. And also nifedipine has also been used in the past, it's been abandoned.
I'm concerned about waiting 24 hours here. Is wait 24 hours, then it might take another 36 hours to patient get there.
Exactly. I think for us, it's not feasible because of our theatre waiting times, the load on our emergency list. But yeah, if you've got a center where you can take a patient, can really take a patient to emergency theatre.
That was what you about.
Yeah, I think you've got to clinically contextualize it. Most of our patients come here beyond that period anyway, of services. But even where you have the resources, it's the whole approach makes me a little bit nervous to use that as a back instead. Then it obviously depends on the suspected or type of foreign bodies, and I'm very reluctant for something sharp. You'll ever wait 24 hours and someone who's already anyway symptomatic. And also for the nature of the foreign bodies is also unknown. And for a coin and children, etc., potentially staying foreign bodies for them that might be a reasonable approach. I also think the risk of esophageal perforation is still very low with esophageal procedure. Missing a foreign body and mediastinitis is very high to the mortality.
What do you do with sweating?
Usually, if the foreign body is in the esophagus, we don't
Okay, so they do flexible.
yeah, now yes.
Yeah, so you get more. Yeah, what do you do? Region. The region.
If it's GI, we'll do it unless it's really upper esophagus.
Okay, so but you're not bothered by it.
We can still bother, and then I think it's a
For people, I can see provide living stuff. I usually like because we are the only there's just one thing. Yes, we're someone to
Yes. Any comments from anyone? Oh, fine. I think the other important point you made, once you remove the foreign body from the scope, it then surely quickly goes surely something distant. So second passage.
I've also just found that quite a few patients when they arrive here after accepting them from periphery, they've already passed the bonus by the time they get here.
Yes.
So maybe our long transfer time is our 24-hour wait period.
That's right.
Yeah.
Other kind of comments and it's happened to me personally is if you have a sharp foreign body, which was there preoperatively on X-ray, and you do esophagoscopy and you don't see it, don't assume it's passed, because they can also move extra lumen. So whether you're going to consider doing X-ray, radio peg preoperatively, just make sure that it's not still there.
Yeah. And that raises the issue with the fishbone. Do you pursue them or don't you?
Actually read
There were any comments about the fishbone that you don't see?
So some places would use CT scans routinely
Yeah.
to try and locate them, either pre or post operatively. And then some places actually use intraoperative ultrasound, a cervical probe, also assists with localization of sharp objects like needles and fish bones and stuff that could be embedded into the mucosa.
But now, if you scope someone, you can't find it. Did you find any mention about the concealed foreign body?
There's no, it seems very varied because I've read of people exploring the mucosa locally, ultrasound, so there's different techniques, but there's no standardized approach to those patients.
Yeah, we always a concern that I get put my arm back to, you know, we beat this, you know, with gunshots, for instance. It was a time when just basically hit it from a shotgun injury back up, but we now know that put my arm, you can't find this university, are you going to be sweet? Find anything.
I would still pursue it because there's reports of fish bones migrating.
Yeah, but even so, you know, we put liger clips into the neck and eyes and neck. So is it going to migrate? I'm not sure where you're going to migrate to. Not going to migrate into the big risk. So I don't know.
I mean, I think if there's a mucosal injury and you suspect and you've done imaging, you don't have that luxury. And there's a possibility that your foreign body, whether it's a fish bone or something else, has traveled extra beyond the mucosa, extra limb. I would at least be a bit more hesitant. I'd be a bit slower to meet patients and also, you know, observe them for an extended period, rather than the patient to assume there's nothing and keep them discharging the
Yeah. I don't know if you're I would be. Because we're going to have to use.
Oh, gosh. Thanks.
So we're talking about foreign body you can't find. The fish bone.
Yeah.
And these, you know, you don't see it reaching the mucosa and, but there's imaging. You just need it when you find fish it out. So that's my sense.
Yeah,
It's just that.
but you can't find it.
So unlikely to